So we'll get started a couple minutes early, and I have no idea how long it's going to take to get through all of the prescriptions, the practical applications, sort of science-based incorporations of this material into exercise, into advice that you might impart on people who are injured, people who have goals, people who are trying not to atrophy, trying to preserve muscle function as they go through life. It could be an athlete, it could be a PT patient, it could be a personal training client, it could be grandma, it could be any number of people who come to you and say, how do I do X? Right? Whatever it is, whatever their goal is, solve for X. You solve it with cell signaling mostly, and interactions, ways that you can hijack that system a little bit or work with it to influence a tissue's behavior. So applications will probably go the whole time, and maybe a couple minutes after, the applications are going to be really helpful for the case studies. On the exam, it's going to be mostly physiology, just straight physiology, maybe a little bit of application, but really concerned with the mechanics of the engine as opposed to the performance of the car. The performance, that's more case study stuff. You know where to find everything. This is a wonderful article. You'll see it in today's folder, today's file folder. If you want to just get an overview glimpse of mTOR, it's a real good one. That's what this diagram comes from. But you should know pretty much every single thing here. I think we've talked about all of it for the most part. But in summary, the mTOR summary, remember, we need GTP loaded RAG, RAG-A, GTP loaded, and GTP loaded REG. If they're not GTP loaded on the RAG side, we don't have mTOR where it needs to be. If it's not GTP loaded on the REG side, we are not turning on mTOR's kinase activity. So these two different pathways to get translation, to get hypertrophy, to get growth. Now, before we do the applications, and I've dropped to the applications I talked about last lecture, which were the value of AMPK and lifespan. Lifespan and blood pressure, heart health, all of those things. You know them, we talked about them. You don't have to know them well, but this idea of crude exercise prescription or crude nutritional or supplement prescription, if you just memorize sentences and say, oh, this particular supplement, have at it, we can encounter some problems. So we'll do a few very brief case studies just to illustrate the importance of understanding science and not just sentences. So Luigi, I was diagnosed with a metabolic condition, mumble some name you're unfamiliar with. I never seem to have any energy, but my doctor said I need to improve my metabolic health. Dr. Mario, AMPK will improve metabolic health. Let's get you on some Ampk activators. Berberine, curcumin, quercetin. What's the problem? They are Ampk activators. Is that good advice for somebody who has admitted an anonymous metabolic condition? I have a metabolic condition. I need to be better metabolically. Metabolic health is really what we care about as we go forward in life. And it is true that AMPK can help with that. AMPK can help with that. Is there a problem in giving this prescription knowing we have some unnamed, vague metabolic condition? Affirmative, I'm seeing nodding. It sounds like reasonable advice, but what do those things do?
What does AMPK do?
What does like berberine do? Let's start with it's a little bit different in these effects, but berberine, remember, what does metformin do? So it's going to build up AMP through several pathways. We talk about inhibiting AMP deaminase, but it also inhibits the first complex of the electron transport chain. So does vertebrate. And what we're looking at with these is these aren't drugs. You can just go get these things if you want. You can just go to S-Mart and get these things. Polyphenols, you can get these things, but it is impairing ATP production in the mitochondria. If we have a metabolic condition and we don't know what that condition is, maybe it's not advisable to start impairing mitochondrial function in somebody who's exhausted with a metabolic condition. Maybe we need to take that into consideration and say, all right, let's get your hydration and macros in order, and let's start you on a treadmill or whatever. Let's start basic. Let's not begin by tinkering with metabolic processes when you have a metabolic diagnosis. It's important to know these things going forward. Okay, now we're at toad. I want to put on some size. Okay, cholesterol is anabolic. Let's eliminate some fiber. And because I'm sure he just eats nothing but veggies, right? Look at him. He's a veggie guy. If you ever played Mario 2, it's just nothing but veggies. Cholesterol is anabolic. Let's eliminate some fiber and include more whole eggs in your diet. Enough with the whites only stuff, those egg whites only. Let's get some whole eggs in that diet. My LDLs are over 200, is that okay? This one's a little more obvious, right? So we have to consider cardiovascular risk here. Toad may be at an elevated risk of adverse cardiovascular events owing to his lipid profile. And while he wants to put on size, he's tiny, right? Toad is tiny, he wants to put on size. That might not be the best way of doing it. There's going to be some more advantageous, less risky ways for toad to put on size. Okay, now we're at Wario. My doctor told me, or something like that. My doctor told me I need to lose weight. She didn't give me much instruction, but she urged the importance of getting my weight under control. What should I do? A few fat loss supplements have come out recently with theophylline in them. That's a better PDE inhibitor than caffeine. Let's start with that and some steady state cardio. I have an arrhythmia, is that a problem? I should have brought the bottle. There's bottles, I didn't make this up. There are supplements with theophylline in them. It's a methylxanthine. Caffeine is a methylxanthine. Theobromine, the one that's famous in chocolate, that's a methylxanthine. But theophylline is a particularly potent one, it's a PDE inhibitor. Sure, this would be of value. Is it an appropriate prescription for Wario? No, because the arrhythmia. He has that arrhythmia, and that's one of the classic side effects of this thing, is the arrhythmia. So a lot of these supplements, a lot of drugs, a lot of compounds are going to have positive effects. They're going to have the main effects, the ones you care about, but they're also going to have side effects of some variety, some severity that you should pay some attention to. And that would be one of them for theophylline. So that would be an inappropriate prescription. There's lots of ways to get Wario his weight under control. Okay, Yoshi, I'm a cross-country runner. The biggest race of the year is tomorrow, and I'm sore. My coach made me exercise yesterday. The pollen is bad enough. All this wind and the pollen, bad enough. The last thing I need is sore legs on top of it. Well, you don't want to make a habit of it, but some NSAIDs would help with the soreness to get you through tomorrow's race. What's a potential complication here?
Is this assumed that he may or may not have asthma or some sort of inflammatory?
That's good, because he's talking about pollen. And so if he's talking about pollen, if you don't have asthma, if your breathing's fine, if everything's normal, who gives a shit about pollen? So yeah, so what's the follow-up sentence?
Oh, like
the mechanism.
It's.
You're totally right with the asthma thing. You can do share credit and go popcorn Liam.
Is it the leukotrienes?
The leukotrienes, yeah. Liam, what were you going to say?
Yes.
Same thing, glucotrienes, okay. Where if you're going to block cyclooxygenase, that's what NSAIDs do. NSAIDs are non-steroidal anti-inflammatory drugs. A steroidal anti-inflammatory would be cortisone, right? That blocks PLA2, phospholipase A2, which prevents the arachidonic acid from even leaving the phospholipid bilayer. But what NSAIDs, what non-steroidal anti-inflammatories will do is arachidonic acid is left, the phospholipid bilayer, and you got to do something with it. If you block cyclooxygenase, the conversion into prostaglandins, yes, you're eliminating a lot of that soreness, delayed onset muscle soreness, a lot of that pain associated with post-exertional, we all know that feeling. You can get rid of some of that. It doesn't really help if you get rid of it. We can talk about that later. Tylenol seems to work a little bit better in terms of an aerobic enhancing drug. But you have to do something else with the arachidonic acid. Lipoxygenase, right? Converted to leukotrienes. Leukotrienes are asthmatic inflammation. So this would ruin his performance. If he's talking about pollen, he cares about pollen. If you give him NSAIDs, his performance is going to be even worse. Now we're at Waluigi. I think that could have been a better name. I'm recovering from prostate cancer. Treatment is over, and my scans have been clean for a whole year. But I lost a lot of weight over the last few years. Compared to Mario, Wario, and Luigi, I am skeletal. How do I rebeef myself? We'll add supplements in stages. Let's get some carbs on board first, glycogen for the beta subunits of AMPK, and some glutamine for mTOR signaling. Later, we'll add branched chain amino acids.
Why later?
This is what Dr. Mario, often that's what you can say, why, to whatever practitioner, a doctor, whoever the practitioner is, why is a reasonable question to ask. GP was team 2. Liam, what team are you? You're barbecue. So, what's the problem here?
I mean, he had cancer, so it might be a problem to just add those amino acids because obviously it was cancer.
Yeah, so nutritionally, we're going to talk about the metabolism of cancer. What does cancer want to see on its dinner plate? What are the two things that cancer really is ravenous about on the dinner plate? Carbs and glutamine, those two things. They're the worst thing to give to somebody with cancer. Now, a lot of things that are going to stimulate mTOR are going to be concerning for cancer survivors. Because, okay, treatment is over, he's been clean for 1 year. No, you're not in the clear yet. Your scans have been, clear 5 years, 10 years. Okay, well, I think we have a little bit more confidence about this. You're clear a year and you want to start feeding cancer already? So we have to be cautious about some of these things. Hunter, what's your team?
6
Okay. And last one, Peach. I have a chronic inflammatory condition, something itis, I don't remember the name, probably from the stress of serial kidnappings. In my years of captivity, I didn't get much exercise. If I'm going to get better, I need to take on Bowser myself. So I need to put on some size. How? Let's start with eccentric loading. Then let's load your supplement cabinet with the whole spectrum, arachidonic acid, phosphatidic acid, branched chain amino acids. We'll go from there. Yeah, let's like ramp up the inflammation. She has an inflammatory condition and we're ramping up inflammation. I mean, arachidonic acid as a supplement? Sure, if you're 19 years old and you just nothing but the gym matters, go for it, right? But if you are, I don't know, how old is Peach? And like, what, 85 was the original Mario, Princess Toadstool, whatever she had a name change. I don't know, maybe was she like 20 then? It's, she's getting old. She doesn't look it, but she's getting old and she has a chronic inflammatory condition. And we're giving her arachidonic acid and we're doing a bunch of eccentric loading, which is going to really exacerbate the inflammatory profile. Not the best advice. So the important part is we need to consider the physiology. We have to consider the person, the biology, right? We have to know science to give advice to somebody that doesn't harm them. As I go through life, most of my encounters, most might be an exaggeration, but barely, a great many of my encounters reveal how harmful exercise prescription is. It reveals a lack of understanding in the healthcare system. Look up the US healthcare system, where we rank. It is not pretty. It is not pretty where the US healthcare system ranks in terms of patient outcomes. Physician error is one of the leading causes of mortality in the US. Mistakes. Now, in athletics, people pretend mistakes aren't catastrophic. They are. These mistakes are catastrophic to people's lives. Follow those people forward 20 years. You cannot participate in a job that involves bodies if you don't know science. If you skip science, if you skip physiology, if you don't understand cell signaling or how cells behave, ethically, this is not a field for you. You need to step out of this field and go into something else. Memorizing prescriptions is a danger to your community. Now, the part of that's its opinion is I honestly think the criminal justice system should step in with a lot more of these cases, including athletic coaching, strength coaching and athletic coaches. That's opinion, that part of it, but I honestly believe the criminal justice system has something to say about collegiate athletics and what we do to athletes in the name of gym science. How many lives have been destroyed by inappropriate coaches at the college level? Okay, public service announcement number 2 is over. Just by way of pronunciation, I don't give a shit if you say eccentric. I don't give a shit if you say it correctly, eccentric. Eccentric technically isn't a word. Like, you look it up. There's the Oxford English Dictionary. That's the best prescriptive dictionary. It's eccentric is how you pronounce it. And eccentric as opposed to concentric, right? Out of the center. The appropriate pronunciation, according to actual publication, is eccentric. You get to say eccentric and nobody gives a shit. I'm gonna say eccentric moving forward, so you know what I'm talking about. Now, eccentric loading, getting into these prescriptions, if you want to maximize mTOR, if you want to turn on cell signaling for hypertrophy, eccentric loading, it's critical. This is pretty critical. Curves, the gym, the female-only gym with that cursive logo, they're concentric only. You go in there, you do a bicep curl and then a tricep press down. You do a row and then a press. There's no negative, there's no eccentric load put on it. Now, what does that mean? Well, here's MAPK, mitogen activated protein kinase signaling. MAPK, ERK, RSK, very anabolic. Okay, here's control, here's a passive stretch. We're not getting much phosphorylation, we're not getting much activation of this signaling. So passive stretch, there's concentric. Concentric doesn't do much either, right? There's isometric, that's better. Isometric, much better, MAPK. There's eccentric loading, huge. So eccentric loading, worthwhile. Isometric, worthwhile, not as good, but worthwhile. Concentric, you might as well just stretch or do nothing in terms of MAPK signaling. So if you want to get good at pull-ups, or you want to get some, at least remodeling some protein synthesis out of pull-ups, just jump. I don't care, don't pull yourself up. Now there's an athleticism to pulling yourself up. If you want to improve contractile performance, specificity of adaptation, do that. But if you're looking at getting the muscle to respond, getting protein synthesis, just let yourself down, jump up and let yourself down. You'll get super sore the next day. Just talking about, in narrative form, eccentric is better than isometric, which is better than concentric, which is barely better than a passive stretch in the hierarchy of loading profiles. Now, eccentric loading, number 2, the second benefit of this is that inflammatory profile. Remember the myokines. The myokines, these little proteins that are released from muscle in the presence of damage. There's also lipids. There's this big chemical environment that is created in the presence of eccentric loading. And we talked about that's IL-15 here, you know, IL-2, IL-15, interferon gamma, all of those things we were talking about are increased in the presence of eccentric loading, and that's part of the signal. That's part of the signal for repair and remodeling. Number 3, those stretch-activated channels. Let's get some calcium into the cells, stretch-activated channels. That signal is augmented with eccentric loading. So the calcium signal is also increased, those stretch-activated channels, that is increased in the presence of eccentric loading. Now this one, mechano growth factor, this is IGF, local IGF, muscle makes IGF, mechano growth factor. What kinds of loads stimulate mechano growth factor the most? Well, there's eccentric loading, right? There's isometric, concentric does it too, but not as much as isometric, which doesn't do it as much as eccentric loading. So isometric is good there too. But mechano growth factor, PI3K, PKB signaling at the local tissue level is most responsive to eccentric loading. Number 5, we have myostatin. This is another myokine. It has autocrine, paracrine, and endocrine functions. Itself, its neighbor, and blood supply. But depleting, this is catabolic. Myostatin, super catabolic. Now we could put, I didn't put it in the list of supplements, but you could go ahead and put, like, in the drugs and supplements, go ahead and put follistatin in there, right? A myostatin binding protein, that's effective. But eccentric loading is going to reduce myostatin. You're going to get a reduction in myostatin levels in response to an eccentric loading profile. Number 6, the reasons that eccentric loading is the predominant signal for hypertrophy. Integrins. What are your mechanosensors sensing? What are the mechanosensors detecting in the load profile? If you do eccentric loading, you get a much bigger stimulus, right? Focal adhesion kinase, FAK, greater after eccentric loading than after concentric resistance training loading. And it's not a small effect. Phosphorylation, where focal adhesion kinase, 8-week levels were 4-fold greater after eccentric loading. It's not a modest effect. The mechanical signaling, it cares about eccentric loading too. Now, eccentric loading is going to do all the damage. If all you do is concentric, you don't really get sore tomorrow. Isometric, you might get a little bit sore after isometric, not as much, but there might be a little bit of soreness. Now, there also is a component of eccentric loading in isometric. If you just flex, part of your muscle is going through an eccentric stretch at the same time, a little bit. Eccentric loading, that's really where you get the damage. When you get damage, that's a signal that you need to repair that tissue. The signal is mostly chemical, but the actual mechanosensors are doing the same thing. Now, lastly, exercise intensity and eccentric actions are increasing satellite cell activity. So that's number 7. Satellite cell activity is maximized after eccentric loading as compared to other forms of exercise, certainly lower intensity stuff, concentric stuff. Eccentric loading, and especially higher intensity activity, maximizes satellite cell activity. Now, more so in type 2 fighters, the big, strong, fast ones that are much more hypertrophic. They're much more sensitive to mTOR signaling. This stimulus is more pronounced in the type 2 fighters. Now, speed of contraction. Limited data here, but there's evidence that the speed of contraction as you're doing eccentric loading matters too. So if you look at, now the speeds they were comparing, 30 degrees per second compared to 210 degrees per second. So slow fast. MGF, mechano-growth factor. So looking at this eccentric loading slow, the amount of mechano-growth factor compared to fast mechano-growth factor, there's evidence that slow resistance training in terms of going down at a slower velocity associates with more of a mechano-growth factor profile for response. I'm not saying you should go slow. Consider the sport, consider the context, think specificity of adaptation, do a task analysis with whatever you're trying to accomplish. And if what you're trying to accomplish is like, look, I just need a little bit more size in here. You know, I'm a football player, I need to hit people, or people are hitting me or something, I need more size. Okay, let's pull all of the stops, as they say. Now, size principle. Remember, size principle is if you can accomplish a task, if you can accomplish a motor task with the smallest, weakest, slowest, most energy efficient fibers, you do it. That's what you do. You don't activate type 2 fibers for a type 1 task. You start with the smallest, weakest, most energy efficient stuff. If that's not enough, it's a summation. You add higher threshold motor units by a little bit. If that's not enough, you add. If that's not enough, you add. If that's enough, that's all you flex. These go unrecruited over here. Unrecruited muscle cells are not nearly as responsive to hypertrophic signaling as recruited, as electrically activated, recruited muscle cells. If you want adaptation through the whole tissue, use the whole tissue. Load it up. Right now, this guy seems to be pulling pretty hard. I don't know about that stance there, but he seems to be pulling pretty hard. At least these two people, they're tugging pretty well. These are activated people. This little kid in her galaxy pants, she's leaning forward. She's not helping, right? So if there's a prize to be won, if there's a trophy, a hypertrophy to be won, she doesn't deserve it if this team wins because she didn't contribute. She literally didn't pull her weight. She didn't contribute her weight to the other team. Same thing with skeletal muscle. If you want a cell, if you want a muscle fiber, a cell to adapt to the stimulus of resistance training, recruit it. Make sure it's used. How do you do that? The most reliable way is get that weight up. It's not the only way. The most reliable way of activating a motor unit is to place a large load on that tissue that cannot be accomplished by low threshold motor units. You can do it with time, right? You can do like 50% of your 1RM and just hold it. You can do a ball squat until you're crying, and you'll start to activate type 2 motor units. Not effectively, though. Not in a way that's going to initiate hypertrophic cell signaling, because that's not the stress being imposed on the tissue. We respond to the nature of the stress. And if you really want a cell to respond, use it. If you lift light, or if you don't go to a degree of exhaustion, you are not activating the high threshold motor units. You may only be activating this much of them. The cells that are the most responsive to hypertrophy are up here. If you're not activating these, you're limiting hypertrophic response. Now, again, what I just said, number 2 of size principle, number 1 was electrically activate the thing if you want to respond, contribute, pull your weight if you want to be rewarded. Number 2 is the nature of that pull, how you pull your weight. It's specificity of adaptation. This is sort of a coupling of size principle and specificity of adaptation. You don't get as much mTOR signaling if you recruit the high threshold motor units with sort of flimsy technique, meaning the wall sits until the type 1s just can't handle it anymore and the type 2s come to their rescue. That's not really a hypertrophic scenario. So you want to incorporate more anabolic signaling. Now, exercise volume. Think FIT principle, frequency, intensity, time, type. The intensity and time and type of exercise If you're using large muscle groups, going for a while with high volume training, that's the situation, that's the exercise condition at which you see the anabolic endocrine system responding most optimally. The endocrine system seems to be most responsive, whether it's growth hormone, testosterone, most responsive to higher volume training. The type of training for powerlifting or Olympic lifting is not for the endocrine system, where you wait 5 minutes between sets. Like you get a pizza and you eat a couple slices between every set. You're on the bench press for like an hour and a half, and you've done 6 sets at the end of it. That's not optimal for the endocrine system. That is optimal for electrical activation of the type 2 motor units. So if that's what you're training for. Now, blood flow restriction. Let's say you're injured. Now, for older populations who have a risk of some cardiovascular thing or inflammatory thing or something, I would be cautious. Some data, not all, some data suggest the effects are a little bit more pronounced among younger folk here. But let's say you can't do a huge load, you're injured. The break point of that tissue is much lower. It doesn't hurt anymore, right? You got the inflammation out of there. You had some injury, you got the inflammation out of there, but the tissue's still weak. This is one of the problems of athleticism. In terms of athletic departments and coaches, and whether it's athletic training or strength coaches or the sport coaches, putting people back into play too soon. If you put people back into play too soon, because the range of motion is there, because there's no pain, potentially the strength is back, maybe there's balance. Okay, we've checked off 4 boxes, and who gives a shit? Those 4 boxes are pretty unimportant. The pain one matters, but pain departs with the exodus of a lot of that inflammation. If inflammation is in the tissue, you haven't even really started to repair the thing. Your tissue has a low break point at that point. That's when the fibroblasts, as macrophages leave a tissue, they release growth factors to call in the fibroblasts. Let's start repairing this thing. It's garbage at the time. The pain is probably gone. You might have range of motion, you might have a lot of, your balance, you might have a lot of these things back. But that tissue is going to be re-injured. If you re-injure a tissue, if you re-injure that tissue, you are going to get the nerve's participation in the inflammatory environment, neurogenic inflammation. A nerve itself is likely to start contributing to the inflammation with substance P and CGRP. The nerve releases stuff to create this inflammatory soup that it's now bathing in. With each injury you load on an already injured tissue, you're welcoming that pain, you're welcoming that dysfunction into your life for longer and longer and longer periods. If you re-injure it too many times, it just doesn't go away. It becomes a squatter. That pain, that dysfunction, that lack of capacity, your inability to participate anymore. That is a permanent resident in your life now. You need to avoid that stuff. So one of the ways to avoid it, A, get a coach who knows science. That's number 1. B, don't load the tissue beyond its capacity. Don't load a tissue beyond its break point, because it will re-break, and re-injuries are bad. Re-injuries are nothing like the first injury. Re-injuries are potentially catastrophic. What are ways of doing that? Well, let's include some blood flow. We still want to get mTOR signaling, but we're not going to load the tissue. We're not going to go through size principle to get mTOR signaling, because the tissue can't handle that load yet. There's a bunch of collagen 3 in there. It's garbage, right? It looks like a spider web or like spaghetti. We don't have a nice definitive matrix of collagen 1 laid down. If you occlude the blood flow and go through resistance training at a lighter load, you can get a lot of the stimulus for cell signaling, for hypertrophy. This lower, not systemic oxygen, but a lower local oxygen better reliance on, higher reliance, maybe not better, higher reliance on glycolysis and glycolytic fibers, more reactive oxygen species, markers of exercise intensity, lactate accumulation. And these things will associate with growth hormone. These are the triggers to get more growth hormone to be released with a lower load. You don't have to break yourself to get this growth hormone response. So here's growth hormone levels, blood flow restriction. Look at the growth hormone compared to the control, the blood flow restriction. Cortisol, you're gonna get that too. And later we'll talk about ways of interacting with cortisol. But the growth hormone response is elevated. mTOR signaling, 3 hours post, right? With blood flow restriction, this dark one, had higher mTOR signaling. P70S6K, higher signaling with blood flow restriction. And then this is MAPK, higher signaling with blood flow restriction. So you don't have to load up a tissue to get cell signaling. Now, I wouldn't do this every single workout, and I would consider the patient population. What you don't want to do is have like an ischemia reperfusion injury in somebody who's sensitive to that, somebody, some population for whom that's potentially problematic. Lifting off the pounds, right? Using resistance training for weight loss. Look at people, look at sprinters. Sprinters are ripped. Find me a talented sprinter without a six-pack. Hard to locate those people. I'm sure they exist, but they're a scarcer entity in their sport. Endurance exercise, it's helpful to have some, certainly intramuscular fat stores. It's helpful to have some fat. Look at the duck breast and chicken breast example. Now that is a selective pressure for the species, right? Ducks fly, they need it in there, and so that's a evolutionary example of adaptation at the species level. But protein synthesis is super expensive in terms of your metabolism, in terms of keeping your basal metabolism, not in its true sense of basal metabolism, but how many calories do you burn from the beginning to the end of the day, not counting activity? This is gonna fluctuate. Now, skeletal muscle, maybe 40% of body weight. Tons of the proteins that are about 40% of the body weight, maybe a fifth of every calorie you burn. Not the same amount that the brain burns. About a fifth of your resting energy expenditure. And you are, in this protein turnover, you are turning over, 1 to 2% of skeletal muscle is broken down every day. A lot of this protein translation, protein turnover, is part of your resting metabolism. It's a huge part of your resting metabolism. It depends what cell you're in. It depends what animal you're in. Are you in a microbe? Are you in a bunny? Are you in a person? Whatever. But when we're looking at this protein synthesis sort of across life, here we're looking at about 75% of the cell's total energy budget. If we go over here, we're just ranking things. Hierarchies of ATP utilizing processes. Protein synthesis above all else. And then RNA, DNA synthesis, sodium cycling, calcium cycling, proton leak. Protein synthesis above all else. So going back to Wario, who needed to lose some weight, one way of getting Wario to lose weight, have him translate a bunch of proteins. Protein translation is going to increase energy expenditure. Energy expenditure and balancing that, those cows in, cows out. The cows out. One way of manipulating that is increasing protein translation. The timing of hypertrophy. You go exercise, how long is this going to take? Now, there's a difference between day 1 of exercise and day 200 of exercise. We see differences in the literature. But there's 48 hours after a single bout of resistance training, 48 hours, 2 days after a single bout of resistance training, we are looking at muscle protein synthesis rates being higher. 2 days elevated. You know, if you go walk on the treadmill, go measure yourself that night, go do it like at lunch, measure yourself at night, you're not lingering. You don't have this lingering metabolic boost. Resistance training, you're gonna be translating proteins for an awfully long time. But at weeks 3, weeks 10, we're seeing less and less and less protein translation unless you map it onto the amount of damage. People tend to respond to resistance training. We are very responsive to resistance training. We build the tissue back to reinforce it against future bouts of that same stress. And if we don't break it down, there isn't as much translation that we need. So the overload principle applies here. The overload principle being, if you just do the same thing all the time, you adapt, and then that's it. Then it just becomes like an activity. It's not exercise anymore, it's just an activity. So you have to apply that overload principle to ensure that you're still getting the tissue damage, so you're still getting elevated protein translation levels. Now, at the onset, most growth, most strength, let's say, most adaptation, most strength, most performance is neuromuscular. Right? It is rate coding, and it is appropriate recruitment of the agonists compared to the synergists and antagonists, and Golgi tendon adaptations, and GABA. I mean, there's a lot of neural changes. But also, you'll see some increase in just general cross-sectional area early on. Early increases in whole muscle cross-sectional area, largely accounted for by damage-induced muscle swelling. It's not really hypertrophy. The cross-sectional area is changing, but this isn't really skeletal muscle hypertrophy necessarily. So the initial increase in size, however modest, is more modest than it actually appears. True skeletal muscle hypertrophy with resistance training, undetectable until 5 to 6 weeks into training, and then we start seeing more hypertrophy. Early on, you're going to be putting your muscle back together. You don't just get damage and that's it. You're damaged forever. You put it back together, but hypertrophy, the growth part, is obstructed. You don't do as much of that early on. You do repair, but you don't hypertrophy early on. Now, again, early on, if you combine, you're a beginner, and you combine aerobic and anaerobic, or aerobic and anabolic, you know, you're gonna do endurance training and you're gonna do resistance training, you can improve in both early on. It takes time to develop a phenotype, to develop your resistance training phenotype or your aerobic phenotype. So you're going to translate proteins for aerobic capacity. You're going to translate proteins for resistance training. During the early stages of exercise training, particularly in training naive participants, there is a significant increase in the expression of genes common to both modalities of exercise. Naive people, untrained people, people unexposed to these stresses, you can adapt in both. It is only with sustained exercise training that there's a fine tuning of the transcriptome, the protein synthetic response, and then the proteome that gives rise to divergent hypertrophic and oxidative phenotypes. Early on, go ahead and do both. Do aerobic, do anaerobic. Do your cut phase and your mass phase in tandem early on. Once you're a well-trained athlete, this is obstructive to progress. Now, the aerobic protein synthesis timing, 4 hours post-exercise, you're really peaking. 4 hours post-exercise is a tenfold above baseline. Next day, your baseline. But after aerobic training, you're looking at getting this response at its climax, maybe 4 hours or so post-training. And again, tenfold. It's a pretty steep climb, and then it drops off. Resistance training, we're looking at, here's 36 hours, up to 18 hours post-exercise, we can get a pretty big increase in mTOR. 18 to 36 hours, there's still activity. You can hit 48 hours and still have activity. It depends on the workout characteristics. This takes time. It takes time to do that part. And early on, you may just be reassembling all the damage. The hypertrophic part may come a little bit later. Now, combining aerobic and anaerobic activity, over here we have aerobic. And you know how this works. We have a bunch of ATP we consume. ATP, 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 consume, consume, consume. We're going to generate more and more and more AMP. AMP is going to permit the activation of AMPK, adenosine monophosphate activated protein kinase. In skeletal muscle, here's LKB1 at the alpha subunit. That's the gamma subunit over there where the ATP, AMP, ADP are going to bind. Downstream from AMPK, we are turning on protein degradation, we're turning off protein synthesis. Now again, early on in exercise training, that's okay, go ahead and combine these things. But anaerobic training, sort of anabolic signals, let's put a little mustache on this guy to really show he's powerful. And all of these stimuli, we are going to go through NAPK, mostly PI3K, PKB signaling, which has the opposite effect of AMPK. So we have competing signals. Aerobic training, anaerobic training, they oppose each other. We have competing signals. They collide. One thing is turning it on, the other thing is turning it off. That's not the most efficient way of exercising. Is having one signal turning on the response that the other signal is turning off. That's mixed signals if there ever were any. Now, some studies have come out which people say indicate that you can combine aerobic and anaerobic training to no deficit. These are the studies that get cited. When you say, oh, it's fine, you can totally combine aerobic and anaerobic training. There's no harm in it. Look up the citations. These are what gets cited. Now, it's funny. You see like William Kramer here, who's the biggest opponent in the world of combining them. And they're citing his work. He gets pissed about that. If you misquote any researcher's study, it is dignified to get pissy if somebody is misquoting you, citing you for something that your study doesn't say. Totally reasonable. Just like, that's not what it says. So here's Kramer's study, et al. There's a bunch of authors here. Subjects had been previously involved with various recreational physical activities, walking, jogging, cross-country skiing, aerobics, or biking. Nobody had done strength training. What do we know about beginners? Build more muscle, who cares what you're doing? You're a beginner. You're responsive with a beginner. Subjects were not on any medications, whatever. And in their findings, at 21 weeks, here's strength and endurance. This is the rate of force development, I think peak force development rate. This is explosiveness or power. Strength training only, strength training and endurance. So that's what you would expect to see. Now, what you would also expect to see in beginners who've never done strength training before to have some responsiveness by the end of 21 weeks. 21 weeks is sufficient time to elicit a response. Remember, you're thinking 4 to 6 weeks before there's anything detectable. 21 weeks, and these people have never exercised before, you expect to see that. But you also expect to see this, strength training improving in the absence of aerobic conditioning, strength training improving power output. And aerobic conditioning not improving power output, actually stripping the power output from the strength trainers who are doing training together. That's what you'd expect to see. Now here's the other one. General design, 10 moderately trained people, there's 10 college students.
Really quick, the bottom line on the graph on the previous slide, that was combined aerobic and anaerobic.
Yeah, this is combined strength and aerobic together. So endurance exercise and strength training, no increase in power. It abolished the effect of strength training on a power increase. If you get rid of aerobic, there's your power curve.
But these were on non-trained individuals.
Yes. Yes, yeah, non-trained. at the advent of training. So these people had, again, recreationally active, which is the same as this study, recreationally active, which just means college students, you like walk to class and stuff, and not like competitive athletes, but just your average college student who plays a game, pick up basketball once in a while, jogs sometimes. Oh, I went for a jog on the levee, whatever, recreationally active. And so that was the same thing here. All males, college students, no lifting, no weightlifting at all. They did 5 weeks of one-legged training, right? Aerobic exercise and resistance exercise. And it was the same people doing both. Just they're separating legs. So, purpose, high volumes of aerobic exercise have been associated with reduced testosterone. Also, no, this is a different study. This is the Hooper study. Apparently I stopped with this slide. But think of, since it's the same people, and like, okay, here's my resistance only leg, right? And here's my leg that does resistance and endurance. They're connected to the same body. If it's like, well, okay, I'm gonna do bicep curls and run a bunch. Biceps and legs have nothing to do with each other. You have systemic circulation. You have an endocrine system, right? You're going to, one muscle communicates with another muscle. So this study makes no sense, and they were beginners, so it doesn't matter, right? So this study is deeply flawed in the way they express things. Now this is Dave Hooper's research, who he's talking about this. Exercise hypogonadal, right? Hypothalamic pituitary gonadal axis. The exercise hypogonadal male condition, where a lot of aerobic exercise reduces testosterone. Too much endurance activity depletes testosterone to varying degrees. It depends on a lot of things. It depends on nutrition, right? It depends on sleep. It depends on training status. It depends on genetics. It depends on a lot of things. But it is a common presentation of a lot of aerobic exercise is a lower testosterone profile. Moving to specificity of adaptation. Specificity of mechanotransduction. Right? Remember, we have integrins and we have cadherins, we have titin, alpha-actin, and we have all of these mechanosensors. And they sense everything about what you're doing. They sense everything about the load profile that you're under. And they submit those signals in the form of chemical messages to the cell to remodel accordingly. So just think about blood vessels and the nature of flow, right? Do you have oscillatory, rough? Do you have rapids? Do you have rough flow? Or do you have laminar? Do you have smooth flow? It changes the stress profile. That changes biomechanical responses. That changes cell signal. That changes the chemical signal. No matter what cell you're in, the load profile changes according, the response to a load profile is different according to the nature of those loads. So looking at mechanical stimuli, in myotubes, and what initiates ERK, MAPK, RSK signaling, and PKB, AKT, PI3K, PKB, mTOR signaling. And there are differences in terms of the stretch profile. The stretch profile that they put on it, uniaxial as compared to multi-axial stretches, elicited different outcomes in the mTOR signaling. It gets very precise mechanical loading. Specificity of adaptation applies to the very specific characteristics of the load profile. So just think every single possible thing. Remember, like total fat and cholesterol, and sodium, and carbohydrate and fiber. And sugar. In our nutritional label, we have something very similar in a load profile. We have magnitude of load, rate of application, direction of the load, the type of load, is it dynamic, concentric, eccentric, isometric, the duration of it. There are all these different qualities that mechanosensors sense and relay that information. Specificity of adaptation number 2, if you're doing isometric training, if you're holding it in place There's angular specificity. Just citations aplenty. You adapt according to the angles at which you hold it. You don't adapt throughout a range of motion. You adapt to the angle that you hold it. Now, if you hold it at a lengthened state, you might get some sarcomere-genesis. If you hold it at a contracted state, you might get some sarcomere-lysis. The adaptations are very robust, and they depend on where you hold it. The specificity of adaptation applies to the speed of contraction. Specificity of adaptation applies to isometric, where there is no speed of contraction. Now, the Alfredson protocol is a heel drop, the calf drop. Tendons don't get inflamed. Tendinitis is a fantasy term. That's a made-up term. It doesn't exist. Tendinopathies. We have pathies in our tendons. True. One of those pathies is not tendinitis. We need mechanical loading to stimulate those tendons. That's what the Alfredson protocol is. There's Alfredson himself on this one. He's done multiple publications on this. A nice article came out in '98. This is a 2003 article right here. Loading it, applying some additional, doing that eccentric load, but wearing a backpack that loads you down a little bit increases the amount of signaling that you get on that eccentric load. Now, contact adaptation. Mike Tyson characterized it very well. Don't write that down. But contact adaptation, in football, these contact injuries, that tends to happen earlier in the season where people adapt later in the season to contact. All right, in the matrix, there are some adaptations. Extracellular matrix, not like Neo and stuff. Aerobic versus anaerobic, task analysis, specificity of adaptation. Agassi talked about that in his book. You get into Wolf and Davis, these early authors. Wolf talked about bones and load profiles placed on bones. Davis was talking about ligaments and other soft tissues, and the lengthening. You get this elongation force, and we respond accordingly. Okay, nutrition, we got our macros. Right, we got carbs, we got fats, we got proteins. Balancing those macros affects cell signaling. So we know carbohydrates in AMPK. Here's glycogen right here. And it says glycogen going down, turning on AMPK. The beta subunits. Glycogen binds to the beta subunits on AMPK. Remember, AMPK is sensitive to the amount of carbohydrate on board because it regulates carbohydrate metabolism. GLUT4 translocation, right? Let's block glycogen synthase. Let's turn on glycolysis, hexokinase, phosphofructokinase. It regulates carb metabolism, so it's sensitive to the amount of carbs. If you have a lot of carbs on board, you can help inhibit AMPK. Carbohydrate is an anabolic dietary component. We know all about protein. We've been doing protein for a really long time, right? Arginine with Castor, cellular arginine sensor for Tor, leucine with Cestrin, methionine with Santor. Glutamine does it in a number of ways, both RAG dependent and RAG independent. And also glutamine, exodus is leucine influx, right? Helping leucine get into the cell. We know those amino acids. Now, you know which amino acids are good, which ones, they're all good. They're contextual. The amino acids that will promote mTOR the most, you know these ones. You can also look up the amino acid profiles in foods, the amino acid profiles in other protein sources. So here's lysine. Lysine is also sensed through SLC38A9, that arginine sensor in the lysosome. There's lysine. I mean, some of these are really low in lysine. What's that one? Corn, really low in lysine. Not just corn in general, the protein in corn. This is the amino acid profile, the lysine profile at least. Wheat, low in lysine. There's methionine. Some sort of like missing. Pea protein is really low in methionine. Methionine is an important amino acid for mTOR signaling. This is essential amino acids, looking at all these different proteins. But here's human muscle. That's what it looks like. for lysine, the percentage of human muscle is lysine, percentage of human muscle is methionine, percentage of human muscle that is essential amino acids. You know how to appraise these things. You know which amino acids are most important. You can just look this stuff up. Now, the timing of protein ingestion, there's a study, it doesn't really matter when you eat it. Some people will ask me before or after. I have seen a study that showed elevated rates of protein translation if you eat it before, as opposed immediately before, as opposed to immediately after. Who cares? That was one study, and you're going to get elevated translation if you eat around your workouts, before, after. Now you can be sensitive to that protein for a long time following a workout. But high quality, so this one, the ingestion of 20 grams of protein, of high quality protein, meaning it has the right amino acids in it. All those leucine and lysine and arginine and methionine, and all these glutamine, these amino acids that are of critical importance. For 4 hours of recovery, it was sufficient to maximize post-exercise muscle protein synthesis. 40 grams of protein just increased leucine oxidation. So 20 grams is sufficient in this study. That doesn't mean 20 grams is sufficient for everybody in all conditions. If you do a more intense workout, if you do a workout with higher intensity, a whole body workout, lots more squats or something, in some of those studies, you'll see 40 grams of protein exceeding the rates of 20 grams of protein in muscle protein synthesis. So it depends on the workout how much is necessary to turn on mTOR, because turning on mTOR is really what's important. Again, so this one, looking at whether it's the timing, how often you eat, it's all pretty similar. But if you do a lot of resistance training, high volume, a lot of muscle groups, big muscle groups, more protein is necessary. In a normal workout, maybe 20 grams of protein. But the muscle can be sensitive to the anabolic influence of protein ingestion for up to 24 hours and likely up to 48 hours. After a workout, you better eat your protein. Go ahead and throw it in before too. Now, with fats and cholesterol, we know that androgens, right, testosterone, this is a steroid hormone. If you eat a high fiber diet, if you eat a low fat, low cholesterol diet, your testosterone goes down. Males in particular, testosterone goes down. But also, mTOR is sensitive to cholesterol itself, just cholesterol levels itself. There's SLC 3889, that's sensing cholesterol. And it is promoting mTOR. But if you dietarily deplete cholesterol, lysosomal levels of cholesterol go down. And the localization of mTOR, let's move mTOR to the lysosomal surface. If you deplete cholesterol, it goes down. In the presence of cholesterol, you can localize mTOR better. So cholesterol on its own is anabolic. Cholesterol is a foundation of androgens, but on its own is also sensed. Cholesterol is also sensed. Okay, supplements. Drugs and supplements. Phosphodiesterase inhibitors. Earlier, I mentioned theophylline is a more powerful PDE inhibitor, non-selective PDE inhibitor than is caffeine. The amount of inhibition given the dose, it's going to work better. Now, caffeine is one of the things, caffeine and theophylline and theobromine and these methylxanthines. Now, sometimes people say like, oh, this only has so much caffeine in it. And it's like an energy drink. This only has X amount of milligrams of caffeine in it. And then you look at the next ingredient and it says methylxanthines or theobromine or something. Like, well, that's the same. That's like, what are you talking about? It only has so much caffeine in it. That's like saying, oh, this drug only has so much cocaine in it. That's crack. That doesn't count. This only has so much caffeine in it. Oh, and the second ingredient is methylxanthine. Or the next ingredient. So we have to be cautious at what a methylxanthine is. Otherwise, you can be fooled by the label on an energy drink. But caffeine pretty much works no matter what your goal is. There's an effectiveness. Your goal is reaction time, your goal is focus, your goal is endurance, your goal is power output. I don't care what your goal is. Caffeine tends to work pretty potently. Now, it actually works worse in coffee than it does in pill form, depending on the nature of the outcome, what it's being used for. Caffeine in pill form tends to work a little bit better than it does in coffee form. But what people are looking at is inhibition of anabolism and saying, nah, it doesn't really seem to inhibit anabolism. You know, we're not really getting in the way. Secondarily, there's a lot of effects of better performance in the weight room, better performance in exercise. What does better performance during exercise figuratively translate to? Not like protein translation, but what does it translate to? Literal translation. Right, so better performance corresponds to better outcomes. So caffeine is effective kind of no matter what your goal is. Protein powder is also effective. Look at the meta-analyses on protein powder. I didn't include protein powder because it's like it's just food. The reason it tends to be effective, it's high quality. You know, whey, you get whey protein, especially. A high quality protein, it's easy to get in a big dose of high quality protein. It's super convenient. That works better. It's harder to organize meals with the appropriate amino acid profiles and doses as opposed to a scoop. The convenience factor of enabling that nutritional profile makes protein very effective. But if your diet gets all of the protein you need at the right times, the amino acid profile is correct and stuff, who cares about protein powder? I didn't include it because I just consider protein powder food. I consider it a supplement. Isolating amino acids. These are what I would say the 5 most important ones. Obviously, these are the 2 most important ones. But these 3 have emerged effective in the literature as well. And you know, glutamine has a lot of mechanisms for how it's exerting its action. But lysine, methionine, arginine, leucine, methionine in the starvation studies. Hunter.
So is it overkill to add like leucine, arginine, methionine, all that into your like just whey protein?
Probably not. It depends how much whey protein you're getting. You know, is it like 40 grams in the whey? Yeah, all right, maybe it's overkill. But people will do protein supplement studies. But by people, I mean researchers, will do these protein supplements augmented with essential amino acids. Not just essential, the branched chain amino acids, but isoleucine, valine, who cares really about those ones? And leucine is the important one. So protein supplemented with additional leucine tends to elicit pretty good effects. But if it's like, you have like 100 grams in your protein shake, like, well, there's already a ton of leucine in there. So contextual overkill. Not inherent overkill in all situations, but it can be overkill. And so this one, leucine-enriched branched chain amino acid supplementation and alcoholic cirrhosis. So sometimes you'll see pathological conditions with muscle wasting. Pathological conditions, you know, it could be cancer, it could be starvation. I mean, it could be HIV-related muscle wasting. There's all of these conditions. So when you're looking at alcoholic cirrhosis, myostatin, there's a nearly fourfold higher plasma concentrations of myostatin in cirrhosis. There are problems with anabolism, problems with protein synthesis and muscle regeneration in a lot of these conditions. And with the cirrhosis population, leucine especially, like pre and post levels of P70S6K phosphorylation. There's ribosomal protein S6 pre-post. This is, who cares? For EDP1, but it's the same thing. This is all in that mTOR signal. All in that mTOR signal, we're seeing the same thing. And more mTOR activity, even in these populations with compromised anabolism, compromised recovery. So sometimes these pathological conditions, it's even more important to put in leucine. Now, again, if it's cancer, then we are promoting growth and metastases with this. Now, there's a reason to worry about chronic sort of relentless use of leucine in the expression of some of these proteins in the cell. So cestrin 2, right, our leucine sensor. If you constantly are just leucine all day long, you are likely to respond. The literature hasn't come up with an answer yet, but it seems it's more than feasible, it is probable that some of the cellular machinery will adapt to maintain, to regulate cell signaling. So you may get additional cestrin, you may modify leucine regulation if you're doing too much leucine all the time. Also, there are a few studies that look at leucine-induced sensitivity to insulin. It's a sort of type 2 diabetes, insulin receptor sensitivity, and branched chain amino acid levels as a predictor for future insulin resistance, going through this PI3K, PKB insulin responses signaling. It's a possibility, but there's also things like this to consider, where you see certain cancers, pancreatic cancer, this elevated amount of branched chain amino acids. But that's cancer-related tissue protein breakdown. And so you're seeing elevated amino acids. So just because increased branched chain amino acids associate with diabetes, the relationship isn't fully elucidated yet. So it's not something to be scared of at this point. There's more to work out. HMB, hydroxymethylbutyrate. This is more anti-catabolic. It's a metabolite of leucine. It's effective in the literature, and there's a nice placebo-controlled trial where it was 10 days of bed rest, supplementing with either 3 grams of HMB or a placebo, and the amount of lean tissue lost. So 10 days of bed rest, like 4.5 pounds or 2 kilos lost in the placebo group. Not much, hardly any weight was lost in the HMB group. So what you see HMB working really well with is catabolic conditions. There's some evidence that at the onset of exercise, you're going to have or at the exaggeration of an exercise response, you're doing some sort of cycle of exercise that's particularly difficult or challenging or breaking down a lot of tissue, that HMB is more important in those moments, in those contexts. Or the HMB can be used in periods without exercise to avoid breakdown. Trimethylglycine, betaine, or betaine as people say, this is, I would say this is more of a maybe, trimethylglycine. It's a methyl donor, but Jenna's study, it's a bunch of UConn people, so I'm familiar with the work because some of these people were my professors. You have some Marish and Bullock and Kramer. Jeff Anderson was the physician at UConn. They don't have athletic trainers necessarily, but they have like physicians, like MDs. And then Jenna, we did our PhDs together. And this is a really nice study where she was looking at growth hormone and IGF-1. Remember, IGF-1 is secondary to growth hormone. Pre-betaine, post-betaine, we're seeing this elevated growth hormone. We're seeing elevated IGF-1, and it translates to elevated PI3K, PKB signaling. So the total resting AKT, maintenance of AKT, that's PKB, P70, S6K, phosphorylation, looking at all of those things. Now, I would include that on the maybe list. That was a good study. Not every study is so consistently positive. Phosphatidylserine. This is a cortisol blocker. It does a lot of things, but it inhibits peaks in cortisol. Cortisol is super catabolic. Cortisol, glucocorticoid, cortisol, super catabolic. And sort of inhibiting mTOR signaling right at the end there. Let's inhibit mTOR signaling. And when you get into phosphatidylserine, here's plasma adrenocorticotropic hormone, right before cortisol gets released. And here's plasma cortisol. And when you put in the placebo, you see a big spike in cortisol. With phosphatidylserine, you're seeing lower and lower. This is a 50 milligram dose. That's a 75 milligram dose. You still get cortisol, cortisol and adrenocorticotropic hormone, but that spike, you temper the spikes with it. And there's some other effects that you see. This one with phosphatidylserine, 10 male subjects, and it was at 15 minutes of intense cycling, and then post-exercise blood work, right? 5, 15, 25, 45, a bunch of times. And here's cortisol, phosphatidylserine, placebo. So it really abolishes pretty effectively stress-induced cortisol responses. Again, so there's the placebo, there's phosphatidylserine, plasma testosterone, phosphatidylserine, placebo. Growth hormone is a little bit lower though. So there's growth hormone, and there's with phosphatidylserine. Lactate looks the same. So phosphatidylserine has emerged pretty effective in especially cortisol, in tempering cortisol spikes. And cortisol is incredibly catabolic, and it's going to increase with exercise right alongside the rest of those hormones, growth hormone, testosterone. Cortisol is going to increase too. Arachidonic acid, you know how arachidonic acid works. MAPK signaling, right? And there are some reasonable studies looking at series like leg press, leg extension, leg curls, hyperextensions, bent over rows, lat pulls, barbell curls, bench press, military press, skull crushers. It's a real workout. This isn't like single leg extension stuff. They're a real workout. And then looking at protein synthesis and the arachidonic acid group, increasing the amount of protein synthesis. Phosphatidic acid is going to work a little bit differently from the DGK mechanical loading version of it. You're going to convert it to lysophosphatidic acid if you put it in your mouth and eat it and swallow it. And that's a pretty good activator of MAPK. It does work. There's evidence that oral phosphatidic acid works. Maybe it's not the best supplement you'll ever take, but there's some evidence that it works. But what we're looking at here, this is just a strength. This is leg press strength. I'm not impressed by something like that. But it's not as effective with mechanical as it is with mechanical loading, phosphatidic acid. Creatine monohydrate. You know what the creatine kinase reaction is. We've talked about that. And creatine will increase, just like caffeine, very different way, but similar to caffeine, creatine is going to increase your workload. It's going to increase the intensity of your workout. You can get an extra rep in that set. That increased workload can translate to more protein accretion. But also, there's some evidence that creatine, you can get satellite cell activity. And so when you're looking at the creatine here and the satellite cells per muscle fiber, the creatine group has more. So there may be secondary effects, and this is just muscle mass with creatine, muscle mass with creatine, muscle mass with creatine. Muscle mass and satellite cell activity, it's a little bit better. Now, gene doping, this is getting into AMPK promoters. Some AMPK promoters, catabolic supplements, which would be great for endurance activity. People talk about gene doping. I don't like terms like this, gene doping. I'm like ICAR, AICAR, right? This is that AMP mimetic. It binds to AMPK and facilitates its activation. But what do you mean gene doping necessarily? Because eat leucine and you modify genetic expression. Eat a banana, and that's gene doping, according to this definition. A banana is gene doping because you get an insulin response, right? Insulin binds to an insulin receptor and alters genetic expression. Okay, well, that's gene doping too then, if ICARs. So a lot of times we're banning things. The World Anti-Doping Code, and I just don't like these definitions because it reveals people don't understand how these supplements work. We talked about Ampk Activators, right? These are helpful contextually. Here are the direct Ampk Activators. There's ICAR. You know what Ampk does. The maybe bother supplements. So that's the end of the, that's for catabolic, but that's the end of the supplements to really consider. The maybe bothers. Vitamin D, if you're deficient, which like everybody's deficient, vitamin D is helpful. Vitamin D is not particularly helpful if you're not deficient. So if you're like, I get plenty of sunlight and everything I eat has vitamin D in it, fine. Citrulline, probably don't bother. I would probably not bother with this one. There's conflicted evidence. It's a popular supplement. Its popularity is not a merit contest. The don't bothers, omega-3 fatty acids are wonderful. These things are wonderful. The evidence is conflicted, leaning toward unhelpful for the omega-3 fatty acids. Lots of claims for recovery, regeneration, protein anabolism, and occasionally those claims hold up. Antioxidants, this is in particular for people with sarcopenia, sort of this age-related muscle wasting. There's an overexpression of reactive oxygen species with age corresponding to a decline in muscle mass, a decline in strength. But antioxidant supplementation for people with sarcopenia has not really emerged all that effective. Tribulus, this was really popular in, like, I don't know, early 2000s or something. And it just doesn't seem to be effective. This is, a precursor to androgens, and it doesn't seem to work very well. So skip Tribulus. CLA, maybe for weight loss, don't bother for muscle mass. CLA, conjugated linolenic acid. And ornithine, skip that one too. Good, benefits have also been observed for its oral ingestion. Thus, acute oral ornithine supplementation, especially with doses greater than that, has been described to increase the growth hormone response to resistance training in both untrained subjects and bodybuilders. But look up those citations, and they're like, you get stuff that's like fake journals. Poorly done. So these positive effects with ornithine, look up the journals, the actual articles themselves, and like they're not referenced by PubMed. But then the studies that are referenced by PubMed don't seem to have the same support for ornithine. So some of these supplements are very popular and don't have an effect. Other supplements are less popular and do have a good effect.
The omega-3s, you said they're good, but not for anabolism.
They're great. They're great for tons of things. Yeah. For anabolism, though, you see conflicted results. And with that much conflict in the results, if there is an effect, it's likely a marginal one. Otherwise, it would be more unanimous in its outcomes. Okay, Wednesday, you guys are up with the drawings. I'll start by reading the case study answers. You guys are up with the drawings, and then the test on Friday.